My name is Dr. Pasquale Cancelliere. I'm a surgical podiatrist in Newburgh, Indiana. The name of the practice is Indiana Foot and Ankle, and I've been doing foot and ankle reconstructive surgery and limb salvage since 2010. I did 3 years of residency in Pennsylvania with Dr. Guido Laporta, who also specializes in external fixation. I've been to the Elizarov Institute in Kurgan, Russia several times to further my knowledge and expertise on external fixation. I did a fellowship at Beth Israel Medical Deaconess Center in Boston, which is a Harvard medical school institution, and now I have tailored my practice to focus on limb salvage and foot and ankle reconstruction through the Elizarov technique, period. I practice with Dr. Andrew Rader and Dr. Michael Nunnemaker and Dr. Darren Serletic, and in a multi-specialty podiatry group. And I'm here today to talk and illustrate about the innovative external fixation technique that is SEAL by D&E. I've been using the system now for about 3 years, and I basically exclusively use the system because of its versatility and its efficacy, and most importantly its ease of application for the surgeon. We do a lot of Charcot reconstructive surgery, cavis, clubfoot, flat foot or talotarsal dislocation reconstructive surgery, and we do all the way up to tibial corrective osteotomies, and at times I've used the external fixator in the case of complex total ankle replacement surgery, and we've just had fantastic outcomes, and it is why it is my pleasure to endorse the system and take you through it today to hopefully show you the advantages that this system offers compared to other systems, and maybe sway you to try it for your patients in your next surgery with external fixation. So what we're going to do today is take you essentially through all the nuts and bolts or components that the system has, and show you how they all come together and how they are assembled, and what options the system offers to make a system or a construct that essentially will be able to correct any pathology and find an application in any kind of surgery that you might be involved with. I think the first component that I want to talk to you about, this is probably the one that gets me most excited about the D&E SEAL system, is the universal clamp system. This is a clamp system that easily fits onto the rings on this frame, and essentially it's made by a external harness that will fixate to the ring. But then when you look at this internal double-ended sphere, which one of the telescoping struts will slide into, will allow you to rotate this strut in any plane and therefore be able to correct any deformity. The thing that this system also allows you to do is truly be faithful to the Elizarov concept of wires first and frame second, because you're not constrained by the size of the rings or the construct that the surgeon might have in mind, but rather allow you to place all the transosseous components and then build the frame to reflect that progressively or dynamically through shortening or lengthening of the graduated struts to bring the foot or leg to an anatomic alignment. And you do that by having at least 4 of these mini constructs attached between 2 adjacent fixation blocks. And through the shortening of each system, depending on what correction or what angular correction the surgeon is trying to achieve, will move the rings' relationship to each other, and therefore move the bones on opposite sides of an osteotomy and arthrodesis site to achieve that correction. One of the constructs that I probably use the most, and I think is really shows how great this concept is a midfoot corrective osteotomy frame. Most surgeons who do a lot of Charcot reconstruction will be very familiar with this concept. This system allows me to apply the external fixation system on the patient, essentially with no incision at this point, just if I was applying any neutralization type construct. And after I've applied the wires and attached them to the ring, I can then undo the screws here, remove the strut, give myself an access to the foot, create my midfoot osteotomy, and through my midfoot osteotomy then be able to, we'll slide this off, to essentially I can dorsiflex the midfoot, I can plantar flex, I can invert or evert, lengthen or compress through that osteotomy. And the advantage of this construct over a traditional butt frame type construct is that this remains a weight-bearing construct. As all the Ilizarov surgeons will know, that the whole idea behind Ilizarov was to allow for early weight bearing. And the butt construct, because of its curvilinear weight-bearing surface, creates a very unstable platform for the patient. These are patients who are already debilitated and have balancing and weight-bearing issues and abnormal gait. It is not very safe to put them in that construct. If you are the surgeon who is comfortable with their application of their external fixator, understands Ilizarov science and technique, will always shoot for a weight-bearing construct, and this allows me to do that, maintain weight-bearing status post-surgically, but more importantly allows for gradual correction. I think the problem with most foot and ankle external fixation applications, unfortunately, is that they are all neutralization type constructs or stress shielding type constructs. We do all our bone work, we are resecting, we are removing big wedges of bone, we're sacrificing a lot of real estate on the bone, and that leads to shortened feet, widened feet, problem with shoe gear later on, and problem with unstable gait and ulcer reoccurrence. By doing a gradual or dynamic correction that allows me to preserve the osseous real estate, if you will, and maintain the anatomic or natural length of the foot, width, and a lot more of the architecture. And I think that really is one of the most important advantages, most relevant advantages of the D&E external fixation system. So once we have applied these systems, there are two T-handles that come in the set. They're very nicely labeled. One is for the red is for the rail, and the black is for the clamp. Once you have attached this harness to the ring, a fixation bolt will go through the ring, and once the nut has been secured, the black T-handle will insert onto this clamp, and obviously rotated clockwise, and that will secure the strut into the universal clamp. I want to bring out that the sphere, the double open-ended sphere, is rough edged. So there's, in my experience, there have been no issues or no occurrences of the strut slipping or loss of that positioning of the clamp. So like I said, once this has been fixated on the ring, we will then slide the telescoping strut. One little pearl that I would like to point out is to think about, if the patient will be doing gradual correction or the surgeon, to leave your access point for this lengthening or compression to where it will be easiest for the patient. And usually that will either be facing towards the head of the patient or facing anterior. You don't want to place a strut so that the patient has to work upside down or reach their strut from the back. So, as I said, usually I will slide this into here and then secure it, and then these other universal joint hinge type setups will allow me to secure the strut just by hand screwing it in, and you can place a nut to provide additional tightening of the strut onto the universal joint. Okay, and then again, once this is in here, then you have the option of wherever that foot plate or other ring might lay or fall, you can secure it anywhere you want and have more selection on the option to where to place that strut. And again, I think that becomes very much relevant when you're applying the frame because you're not sacrificing wire placement, you're not sacrificing positioning of your osteotomy so that the anatomy or your osteotomy fits the frame. You're truly preserving the spirit of the Lazaroff reconstruction philosophy, where it's wires first, osteotomies second, frame last. The nice thing is that once you've achieved that position, you can then also apply the more traditional or conventional stability systems with threaded rods and nuts and clamps that are available in the set. Nice thing about the wires that come in the set, they either have the traditional, what are called skinny wires, or javelin tip type smooth wires, and those come in both 1.8 and 2 millimeters. In my practice, we use the 2 millimeters. We feel that it provides a lot more stability. And then you have the beaded or olive wires. The beaded olive wires are great, and in the instance where the surgeon is trying to translate bone, but we found that in most applications of arthrodesis and limb lengthening, the smooth wires are perfectly capable of achieving the correction without needing the bead. The set also comes with the transfixing half pins, which are also fantastic in a deformity correction or a trauma type application, where the only purpose is to stabilize the anatomy. They can be used, and they're absolutely fantastic. Another thing in my practice that me and Dr. Andrew Rader do is a lot of times, trying to be true and faithful to the true Lazaroff philosophy, is use 3 transosseous wires per ring. And we found that adds a significant amount of stability. And because D&E offers a 2 millimeter wire option, it allows to alternate between your transfixing half pin or the smooth wire. The wire will then be fixated to a fixation bolt, which is nice because it gives the surgeon several options on how to tension the transosseous wire. The surgeon who's more comfortable with a barrel tensioner can slide the wire through the central slot of the fixation bolt and then use either the barrel tensioner or the compression tensioner. What that essentially does, it pulls on the wire without affecting the fixation bolt in any way. The way that in my practice we prefer to tension the wires is by using the side slot through the head of the bolt. Once the nut has been properly fixated on the opposite side of the ring, then we'll use the bent wrenches or the straight wrenches and literally wrap the wire around the fixation bolt. There's a couple reasons why we prefer to do it this way. The first one, well, it's easier, it's faster. The second one is I can tension really, I think, more effectively. That's not to criticize or critique the efficacy of the barrels or the compression tensioner, but I feel that I can more customize and get more of a feel for how much tension I'm applying to that wire. And in our experience, it's just been the way that we tension wires. I think both options and both techniques are absolutely valid and both equally effective. It's all a matter of surgeon comfort. I think with the way the wires are made and the thickness of the wires of the D&E seal system, the surgeon truly has the option of doing what he or she prefers and is in no way constrained to one way or the other. So here we have a construct that is both can be applied as a neutralization construct or as a dynamic construct as well. If this was a trauma application, this will allow us to neutralize the anatomy through ligamental taxis and reduce the deformity of the trauma, and then allow the patient for early weight bearing without any problem. But let's assume that at some point there was a need for some kind of corrective osteotomy. We'd be able to do that even after the initial reduction, by just simply removing the fixation bolt, sliding the strut off, and then accessing the anatomy in whichever way is most appropriate, performing our osteotomy or bone work or wound care, or access to the wound without losing the stability of the construct, and then reapply it, and then easily convert this system from a neutralization construct to an active, dynamic, corrective type construct. The other thing I'm very excited about using the seal system is these little rocker bottom applications. These, we'll call them accessories, allow the patient to essentially roll off them when they're walking, making gait much easier on the patient without sacrificing balance or stability. Once they are in mid-stance, the patient will not lose their balance. And because they're a solid type construct, they will support even some of our more well-nourished patients. So this is a great system. And again, it's extremely stable. It will not fail you at any point. One advantage I think it has over a talar spatial system is that with the talar spatial system, because of the positioning of the struts, if you remove one strut, you have to replace it or else the system will collapse. With this system, because of the way the struts are designed and built, I can remove or displace one of the struts and not sacrifice any of the stability. With this system, we usually do not use more than 4 of the clamp and strut assemblies, whereas other systems require at least 6, maybe because of inherent lesser stability of those other systems. Going back to my midfoot construct here, again, once I've achieved the position, I can always apply another construct to connect my half ring to the distal tibial ring to provide increased stability. And because of the ease of the disconnection, at any time the patient has to do the correction, they can just simply remove that system, change the length of the struts based on the program that I've designed for the patient, and then reapply it to maintain that stability. And that's one of the many reasons why I think the D&E external fixator system is much more versatile, much more stable, much more effective for the surgeon, and allows a lot more for the surgeon's creativity and talent to be expressed during the surgery.